for carotid Doppler, the neck vessel Doppler, we'll try and look at the two things. One is the carotid artery and part of the venous system. Carotid artery would start somewhere just above the clavicle. You can start in a transverse view and maybe try and make the patient turn slightly opposite sides to get a little bit of better opening. And before you proceed, just try and see the origin of carotid, which will be coming from the brachiocephalic artery, and it will form a nice Y-shaped structure which will allow us to understand there is a subclavian and there is a carotid. So there is a carotid here which shows a good IMT here, and if you go this side, that is the subclavian artery. And if I were to see it a little further downwards, I am sure I will be seeing nicely the entire aortic arch in cross section. I will try and reduce the frequency slightly so we get a kind of better penetration, and we will open up the trapezoidal or wide view which allows us to see the complete arch of aorta in a cross section. So from there onwards I can trace the artery upwards, and now I would quickly turn to 90 degrees and get the artery vein together in cross section. Having done that, it will be very easy for us to complete the carotid Doppler in a nice complete sweep from this side till we reach the bifurcation. So we go onwards, and I tend to very often use the dual live view which allows me to see both things together, and then I'll just from downwards I'll continue just keeping concentration on the carotid artery and keeping it in the center, trying to see if I get a wall to wall complete feeling, which will be slightly better when you're in single color view, and then you reach till the bifurcation where this artery gets divided into two, and there will be distinctly two vessels. We will be trying to understand which is ECA and which is ICA, but by just our common convention we will understand the larger will be ICA, the smaller will be ECA, the one which goes medially will be the ECA, and one which dips down posteriorly will be the ICA. So this is what it should be, and then we'll check one more method would be the taking the spectrum. At the same point you will see the jugular vein here, though it's reverse color, we can just convert it for our better understanding and complete the study from here downwards. In the carotid sheath there is only one other structure which is of some importance, vagus nerve, which will be sometimes, rarely it will be showing some additional findings in that area. Otherwise it's the carotid and the jugular in a very loose connective tissue which will be completing your carotid sheath. So we've done this, we come back. Now that we have to take a spectrum, and we have at least seen that the bifurcation shows correct flow, so your job is more or less done about this side of carotid. Now what remains is the vertebral, which we'll see subsequently. Now we'll be seeing it in a longitudinal view, and again I'll be continuing it and running through till I reach the bifurcation. Here again there may be a tuning fork which occurs in some patient and it doesn't occur in some patient, depending on the angle how it is located. You will be seeing this from the side view, the complete ICA in the neck. If you want a better view, you can slightly use the trapezoid to you can see longer portion of the ICA, and likewise little bit more medially there will be ECA which will give rise to one branch. So this will be the ECA here and this will be the ICA here. And now we have to decide what are the spectra we are supposed to take. We at least should take 3 spectra. One is in the 2 centimeter away from the bulb in the common carotid artery, and one is in the proximal ICA, so that will allow us to take the ICA-CCA ratio, which is a very important measurement for knowing the grading of stenosis, and we'll also take one velocity in the ECA. So we'll go, and while taking the velocity is better to not use the wide view, so we'll switch it off and we'll switch on the color, get the image in the center, and I'll try and convert it for a better viewing. And then this is a LumiFlow. If you want, keep it on, or if you want, can remove it. It depends on your personal liking. I prefer without LumiFlow. Then I'll just go ahead and take my cursor little bit 2 centimeter away from the bifurcation and keep it in the center parallel to the lumen and parallel to the flow in this case, but if there's a stenotic area, it should be parallel to the flow. So we'll just adjust this correctly and take one first spectrum by updating. So that's our spectrum. Waveform is correct. There is no broadening seen because of the artifactual thing. So we'll just adjust our game and we get a good spectral window when we freeze this image. So I'll freeze this image. That's your typical carotid flow, and that is a nice kind of spectral window which is seen here. That would be the area where we would take one velocity, which would be the peak systolic velocity. Many machine would take the end diastolic velocity when you are calculating the degree of stenosis, because the end diastolic volume also would change with the stenosis, which will be subsequently lower down. So, but these are the two measures you take. Many machines would have a structured reporting system into which you can just feed this in. Beyond that, now we'll move towards the bulb. Plaque characterization is done by simply by B mode, and the B mode characteristic would be either the plaque which is very acute kind of thing, will be black plaque, so you may have to increase your color gain and reduce your tissue harmonics so that you see those plaques better, or they can be gray, which is an intermediate plaque, and then will be a calcified plaque if it is one. So black, gray and completely white, these are the three types of plaque. At the same time you will be seeing the surface of the plaque for the ulceration or any irregularities or any eddy currents which are occurring, or if there is any true ulceration within the plaque. The machines which have microvascular flow, they can sometimes show the flow within the plaque. If it were to be there inside the plaque, you may see sometimes the vascularity within the plaque. Other application to characterize the plaque is by sometimes using the contrast enhanced ultrasound, and you can characterize the plaque with using a very sensitive method of flow detection. So this is your microvascular flow, which will allow you to pick up if there is any sometimes very less flow or negligible flow in the plaques. So we come to this point, we looked at the bulb. In the bulb there will be occasions where will be seen a reversal of color, which is called as flow separator. In fact, flow separator gives you idea that there could be, it's a good vessel, because there will be marginal reversal into the bulb area in certain patients, and that is considered as normal. In fact, that is considered as a sign of a good hemodynamic circulation. So in this area, it is not seen here, but if I were to show you, there will be reverse blue flow here, that is due to flow separator, which could be either on both sides, one side or the posterior side. So with that information, now we'll check the ICA. In the ICA, in the proximal portion, I'll keep my cursor into center and maybe adjust my quick scan sometimes, which helps to get a better spectrum, which is correctly taken. So now we'll go on to the calculations. In that, here there is a laterality. We'll choose the right one. So we have chosen the right one. That's the ICA. In the ICA, there will be again proximal here location. So we can go for distal, mid and proximal. So we'll go for proximal, and I'll go for limited trace, which allows me to completely measure these two things together. So it is at least two spectra will include, two waves will include. So we get a peak systolic and end diastolic volume here, and this will be stored. And at the same time, as I showed earlier, we will go back to the CCA and store that again, so that we get a radii ICA CCA ratio. So this is the method by which we will complete the ICA CCA ratio. While doing carotid, it is important not to give too much of probe pressure, otherwise you sometimes get a spurious rise in the velocity. So it has given me the velocity here, and this will automatically calculate your ICA-CCA ratio, which you can calculate even physically later on. So these are the two things which we looked at. Now is the third artery, which is the external carotid artery. If possible, we also can take one more ICA measurement little bit distally, and that can be done in instances where there are disease processes, because The proximal ICA stenosis will cause post-stenotic turbulence, and which will be documented when you take spectrum little bit beyond. So that will be the one additional thing you can take and measure this as a mid ICA level. The distal ICA per se will not be seen very well on the carotid Doppler study with the regular probe. Sometimes we use the intracavitary probe angle, and that allows you to see it beautifully. And patients who have short neck, that is a very nice trick by which either you can use a intracavitary probe or a cardiac probe and get a better span completely across the carotid bifurcation. Now this is our other artery, and there is a branch also is seen here. So this is likely to be ECA. Very, very rarely ICA can have a branch, but that's almost a case report kind of thing. So this is our ECA. And one additional thing, ECA will be further showing flow difference. This is a young man, so he will have a little bit hyperdynamic circulation, so it will be slightly with more thrust, but by and large you will see the difference in the flow. So at this point, some advocate to use the temporal tap, which I am doing. Hello Naka, zara. Just update for me once. Yeah, okay, so let me be in the artery correctly. Yes, okay. Start again. Yeah, okay. So that shows nice temporal tap, which allows us to think that while I am creating a peripheral resistance by giving multiple taps onto the external carotid artery, it will be reflected into the circulation, and that is why we see this temporal tap. And it is again very specific for external carotid. Very, very rarely in a thin patient, ICA tap also can sometimes reflect, but overall the flow is different, and we saw the branch. So we recorded this as the external carotid. Now after seeing the the origin, we would also see one more artery, which is the most important artery, would be the vertebral artery. Vertebral artery in a thin patient would not be very difficult to see. You would understand that there is a carotid. You will have to come little bit laterally. There will be transverse processes, and the mass of the transverse process is causing this shadowing, which is your landmark. In those two landmarks, you will see two vessels but generally in most of the patient. Sometimes one vertebral could be slightly hypoplastic. In those scenarios, our preset can be tuned in to go to little lower flow. So many times in some machines it is advisable that you create a vertebral preset separately by reducing your flow velocities and increasing the color gain, and we will now switch it on. But on good generally machine and a thin patient, you don't have to do that, but in certain patients you will be required to do that. So we will see this completely. Now we are seeing at least two good segments of the vertebral artery and the vertebral vein. Obviously you may have to look at the color of this vertebral artery and vein. Why it is important? Because that would be your first clue towards the vertebral stele, that one has to see that this color, one is red, one is blue. If both are blue or both are red, whatever color bar you are using on the opposite side here, keeping watch onto that we know that this is coming this side towards the probe, so it's blue, and this steering, it allows me to say this is away from the probe, so this is red and blue, so that gives me a good comfort that there is no stele here. If it were a stele, you would maybe sometimes see complete reversal or a transient flow reversal within this picture frame. So we will check that, and then we'll go back to vertebral just to complete this area. Take a spectrum here, which is expected to be somewhat like common carotid artery. As you can see here, the window is very clear here, and we'll take one velocity here just for the completion, and we'll try and generate a report. If there were a stenosis, the method would be available on the machine, which is called as the area stenosis, which is what we commonly use, and we also use in conjunction the peak systolic velocity ICA-CCA ratio. So now we'll go back, take one last vertebral artery, that's again proximal, right side. This should generate me a report which is available here, and it tells you the various parameters, whatever you are generally wanting to see, because as the velocities would increase, we would be looking at whether there is a stenotic segment. ICA-CCA ratio is here, peak systolic 0.80 and 0.83, so this is a good ratio. one important thing about the origin of the left ICA is seen better when you increase the field view and reduce the frequency slightly. So you'll see a better penetration, and you'll almost be able to see the origin, because tandem plaques are common and they can arrive, they can be sitting at the origin of the carotid artery, and from there you would see whether there is any stenotic plaque, which you can sometimes miss, and it can create a spurious velocities. By not seeing that plaque, you would probably make that small mistake.